and our esteemed guests and public commenters for joining us for the first meeting of 2017. We acknowledge that we have not assembled a quorum, so we will not be taking any actions on any of the agenda items until a quorum is established. But out of respect for those who've come a long way through what sounded like ferocious vehicular traffic, we want to respect your time and begin with the presentations and programs this evening. So again, welcome, thank you to everyone. I think we would do roll call and other agenda items after we have a quorum, is that correct? Because those are formal and official agenda items. So perfect. Nicole, please welcome our first, Commissioner Vick, please welcome our first speakers.
Perfect. We have a presentation by Dr. Paul Song, radiation oncologist from LA Radiation Oncology Center at Dignity California Hospital. Also co-chair of the Campaign for a Healthy California National Board member, Physicians for a National Health Program, and 2013 visiting fellow of the California Department of Insurance. He's speaking today on the repeal of the Affordable Care Act and long-term strategies to protect health coverage for Los Angeles City residents. Welcome.
Thank you. Do I need to? Okay, so thank you so much for having me come here today. What I wanted to do was give you a little bit of background of what things were like immediately in the run-up to the ACA, since we may be going back to that, and then talk about how the ACA impacted us here specifically in California and what the pending repeal will mean for our state. So this is a slide that many people have seen. If you want to just turn your attention to the slides over there, this is just showing you that, you know, pre-ACA and even after the Affordable Care Act, we spend twice as much per person on care than any other industrialized nation. And in spite of spending twice as much, we have higher infant mortality, lower life expectancy, and by every metric, we are ranked the lowest in terms of healthcare systems if you look at all the other industrialized nations. And prior to the Affordable Care Act, we had close to 51 million people in the United States that were uninsured. Just to give you an idea of who these people are, so 8 years ago we had this debate about takers and makers, and the idea was that the uninsured were all takers. But the reality is that nearly 2/3 of all of our uninsured are full-time workers, and most of these people actually have multiple jobs. And this is just showing you in the state of California the percentage of children of people that are uninsured. And you can see, again, the majority of children who are uninsured, their parents are full-time workers. Chances are they're working minimum wage jobs where they don't have health care benefits. And it's a real issue. And this is, as you can see, 2015, even with the Affordable Care Act, we still have over 335,000 kids in the state of California who are uninsured. So one of the real issues that the Affordable Care Act really did not address was the issue of medical-related bankruptcies. In 2014, there were 1.7 medical-related bankruptcies, which were 62% of all of the entire bankruptcies for that year. And of those people, 1.7 million, 70% had insurance. And you often wonder, I thought insurance is supposed to protect you from catastrophic financial ruin, but that is simply not the case. And as an oncologist, I saw that all too often when patients of mine would go bankrupt strictly because they got sick. So this is just illustrating again, after the Affordable Care Act, that while it did some good things, a lot of patients still had major financial problems when they got sick. And you can see that the dark orange really represents patients who are uninsured, but everything else, the orange line in the middle is really the group that I call your attention to. And it's just basically showing you that people with insurance, when they got sick, 44% received a lower credit rating, 47% used up all of their savings, 34% took on credit card debt, and 7% had to declare bankruptcy. So this is a major issue that was not readily addressed by the Affordable Care Act. And when we hear, people now saying individual freedom, I just want to point out that in the last 9 years, the largest insurers in the state of California have issued over 45.7 million denials of claims here in the state of California. So when they say they don't want the government coming between you and your patient, provider, it's actually the insurance companies that are doing this on a daily basis. This is, again, just showing you what insurance rates were over the last few years. It's actually Since 2002, insurance rates have gone up 185% in the state of California. You can see in the lower corner the average national wages. So while insurance continued to climb, and the blue line is inflation, climbed marginally over a long period of time, wages remained stagnant or actually decreased. And with these large premium increases, you could see the insurance companies became increasingly more wealthy, and they used a large percentage of that money to lobby Congress, and that's why the Affordable Care Act did not have any insurance rate regulation built into it or any drug price regulation. It was so bad that The Lancet, which is a very well-respected medical journal, dedicated a full issue on the Affordable Care Act, saying that the healthcare reform process exposes how corporate influence renders the U.S. government incapable of making policy on the basis of evidence and the public interest. So, in spite of that, you can see the uninsured rate of Americans dropped considerably from 51 million to roughly 28 million, 29 million. So a large percentage, and the uninsured rate dropped to the lowest it's been in many of our lifetimes. This is showing you in California how the Affordable Care Act greatly helped all communities of color. Specifically, though, you can see that in 2013, the top line, and then with the lower line, that our uninsured rate dropped substantially to really, if any state felt the effects of the Affordable Care Act, California did, and it was across all ethnicities. One of the big fallacies of the Affordable Care Act was that it would be a job killer, and this is just showing you from the time that it was implemented the private sector employment growth. So that clearly never panned out to be the case. And in California, the same thing. This is California. If you look, while the percentage of employer-based health care has dropped over the last 30 years, and we rely much more on public programs, the light green line, 31% of all of our health care is from public programs, our uninsured rate continued to drop while unemployment continued to drop as well. So it has not been a job killer here in California as well. So 4.6 million Californians gained coverage due to the Affordable Care Act. Some were marginally because of employer-based and recovery of the economy. There were more job people being hired, and you were able to get health care that way. But you can see the greatest amount of people that got coverage was through the expansion of Medi-Cal. Some people became 65 and eligible for Medicare, and then you have the other group with the individual plans purchased on the exchange. Now, I just want to say a couple things about the Medicaid expansion, because it really is going to get to the heart of where California is going to face its biggest challenge with the GOP repeal. So Medicaid expansion was really designed, they expanded it for people with incomes up to 138% of the poverty level, so it was roughly people making $32,000 a year for a family of four. So you could see a lot of people in our state working in minimum wage jobs who would not get coverage through Walmart or some of these other places who are now getting coverage here. So now we have roughly 1 in 3 Californians on Medi-Cal. We have over 5 million children, including children of undocumented kids. We have 1.2 million that have gained coverage on Medi-Cal since the Affordable Care Act. And the level of uncompensated care, which is very important. So when I worked at Cedars didn't have as much uncompensated care as California Hospital does. But the level of uncompensated care is 21% lower, and that's substantial to a lot of these inner city community hospitals that are meeting the needs. Again, this is just showing you the degree of uncompensated care in the non-expansion states, the states where ideology trumped any Medicaid expansion versus the Medicaid expansion states. So you can see it's been very helpful not only to patients but to hospitals, and as a result the hospitals have ended up hiring more people, and this has created more jobs in the state of California. But there are some major problems, okay? So even with the Affordable Care Act, there are 29 million people that were still uninsured nationally. And in California, even though we had 4.6 million Californians gain coverage, there were nearly 3 million people, 2.9 million people that remained uninsured. Some of them remained uninsured because they just could not afford the premiums of the insurance premiums. Some because they were undocumented and not eligible for coverage. and others simply just felt they were too healthy and didn't see a need. But the majority of people who fall into this category really fall into the first two. And just to look at who really these uninsured are, of the 2.9 million, roughly 60% are Latino, 1 out of 3 are undocumented, 1 out of 5 have an annual income of $75,000 or more. And you can see that age group 25 to 34, that's sort of what we consider an invincible. They think they're too healthy and they don't need health insurance. And then 1.8 million of that group are employed. So these are people that are working hard, trying to do the right thing, contribute to our society, and yet they can't afford health care. So here's the inconvenient truth about the Affordable Care Act. The average family premiums in the state of California are roughly about $16,000 per year and continue to climb. We're all asked to pay higher copays and deductibles every year, and the premiums continue to increase. 36% of people delay seeking a doctor because they can't afford the copays and deductibles. And once you get sick, 35% still cannot afford to pay their medical bills. And yet there still is no provision to regulate excessive insurance premiums. We tried that with Prop 45, which was soundly defeated as the insurance industry outspent everybody, and then the drug prices continue to escalate. So this is just showing you again that if you look at, again, the orange line, the number of people that were insured all year who delayed seeking care because of the cost. And you can see it's a substantial. Up to 44% did not fill a prescription or skipped a medical treatment or did not see a specialist or even go to see a doctor because they couldn't afford the copay or deductible. So you scrap all your money together, you pay a premium, but then you don't use it because the copays and deductibles are so high. This is showing you again, it's by individual, healthcare, Medi-Cal, employer-based, that the delay in care because of cost is pretty, it's there for everybody. And what's really interesting is if you look at the individual plans, that these are people that purchase Uncovered California, roughly 62% of the people that delayed care said it was because they couldn't afford the copays and deductibles. So in some respects, Covered California is a success, but on other hand, it's a little bit of a scam that you're buying something that you can't really use. So the other thing you'll hear about is that the narrow networks. So what that means is that when you sign up for a plan, there are very few doctors in your network that you can even go see. And this is, California actually ranked as one of the worst. Of all the states, it was in the bottom 3 of 50 state exchanges in terms of narrow networks. 75% of all the plans had narrow networks. And the other thing is just showing you that the deductibles continue to climb in California and it becomes less affordable. And this is just showing you what the average deductible is. So the bronze plan is the cheapest plan that you can purchase on the exchange. Your out-of-pocket expenses before insurance kicks in is $5,000. I don't know many people who have $5,000 sitting around in their pockets to meet those expenses. So again, they don't choose to use the coverage that they paid for. This is just showing you that not only are wages remaining stagnant, but workers are being asked to contribute more and more towards their health care costs, both in terms of coverage, but in terms of deductibles and premiums, and yet wages and inflation remain relatively flat. And just so you know, everyone's focused on what will happen with the ACA repeal, but California has a $150 billion unfunded retiree health care debt. And I'm not sure what it is for Los Angeles, but I imagine that's the case as well. So we need to think boldly. We can't just continue the status quo because the Affordable Care Act in no way addressed this underlying ticking time bomb. So why are we getting so much, spending so much and getting so little? This is showing you that in 1990, if you look at this graph, the red line down below is the growth in the number of physicians, and then the yellow line is the growth in the number of administrators hired by insurance companies to basically deny care and increase profits. And if you look at the black line, that is the line percent growth in U.S. healthcare. It remained, pretty similar to all the other industrialized nations. But then when all of a sudden we got into this huge private market and it became profit-oriented, you see this explosion in healthcare costs. This is again showing you where the United States is. So look back to 1990 on this graph. We're even with all the industrialized nations. And what did we do? We started to privatize everything, and look what happened to our healthcare costs compared to all the other industrialized nations. Also, in spite of that and all the money we put in, we have the least efficient healthcare system of any industrialized nation. We actually waste more than at some points our defense budget on healthcare spending. And this is waste in healthcare spending. And so I just want to talk a little bit about an efficient system, Medicare. Now, you'll hear Medicare demagogued a lot in the upcoming months. You'll see a concerted effort by the Republicans to repeal Medicare or to privatize it or to ultimately find ways to dismantle it. But this is just want to show you that Medicare takes care of the oldest and the sickest patients, showing you that the majority of patients who are on Medicare have 3 or more chronic conditions. And in spite of that, don't believe the hype. The private insurance industry does a worse job of controlling costs compared to Medicare. Medicare is the one government service that actually runs efficiently. When you hear people say the government's incapable of doing anything, it's incapable of continuing to give people subsidies for private insurance, but in terms of handling its own healthcare system, it's actually quite efficient. Now, this is just showing you that in 1970, the United States and Canada had roughly the same healthcare costs of a percentage of GDP, and then Canada instituted its single-payer Medicare for All plan, whereas the United States decided to do the HMO Act, which led to more privatization of healthcare, and look what happened. This is, again, just showing you the Bloomberg World Rankings in terms of healthcare systems. You notice the United States is nowhere on this list. And in spite of paying less and all these systems, South Korea has a single-payer system and had the highest world healthcare satisfaction ranking among its citizens. So in 1995, the Republicans started to begin to privatize Medicare, and they said that if we put 20% of all Medicare beneficiaries in private HMOs, we'd save $270 billion over 7 years. But instead, we've overpaid $282 billion since that time. So that's been roughly a $550 billion swing. So when people say Medicare is broke, I think Medicare is broke because Congress is constantly interfering with it. This is showing you, again, Medicare Advantage plans are more costly than traditional Medicare. This is showing you also that Medicare is prevented from negotiating drug prices, partially because the majority of Congress is bought and sold by the pharmaceutical industry. Above, you will see the federal lobbying expenditures by the top 10 pharmaceutical companies. It's staggering. And you will see how quickly drug prices are rising for Medicare Part D. And what's happened with that? You're seeing profits at the pharmaceutical companies just explode. And as a result, 22% of seniors can't fill their prescriptions because of cost. They spend excessive amounts of the profits on, a minuscule amount of the profits, but an excessive amount nonetheless on lobbying. We still can't import drugs from Canada, as you saw, the Democratic senators who torpedoed Senator Sanders' amendment. And the average American loses about $1,600 paying for excessive costs for drugs. So I just want to talk now about what is going to happen. While there's no specific discussion as to what the repeal or replacement is going to be, what we do know is that the repeal of Obamacare as we stand right now would cost nearly $550 billion over a decade, because it actually reduces our deficit. And really, 21 million people would stand to lose coverage. In the state of California, it's estimated that anywhere between 3 to 5 million people will lose coverage. The other thing is, if they allow pre-existing conditions to discriminate, this is just showing you that in the state of California, roughly 1 out of 4 people in California has a pre-existing condition, and that 52 million people nationwide would be considered declinable because of a pre-existing condition. So there's a lot of angst out there. This is all showing you that this is the most substantial slide that I will say in terms of the future of California's healthcare system. They're expecting that the House will replace Medicare grants. Remember, right now, the government is paying 90% of all Medicaid expansion costs, and they're going to replace that with block grants. And this is just showing you that every year you go out, the deficit will continue to grow. And in California, and then this is also showing you that in California was promised $2 billion over the next 5 years, to cover uncompensated care. This is on top of the $20 billion it gets each year from the federal government for the Medicaid expansion. So here's the effects in California. So we know that the repeal could cost California as much as $20 billion in annual federal spending, which is roughly 18% of our entire state annual budget. We already pay $20 billion of our own general funds towards Medi-Cal, and people in Sacramento have already started to think about raising state income tax, but that would require a 25% increase across the board for everyone living in California in order to fund this deficit. And reducing the number of California, or the other choice is we would have to reduce the number of Californians to meet that $20 billion federal cut, and that would mean kicking 4 million people off Medi-Cal or covered California. So this is a real major problem that we are facing in California. Now, a couple things. I'm a single payer proponent, and it turns out so are the biggest insurers. The insurers are all moving towards rapid consolidation. So when I talk about single payer, people will say, well, you know, make an argument. But here's the thing. These insurers also recognize the benefits of a single payer system. It's more efficient, cost effective. But instead of passing those cost savings on to its consumers, they'll pass it on to shareholders. A single payer system in the state of California, back when Sheila Kuehl's bill passed both houses only to be vetoed by Governor Schwarzenegger, it was estimated that a single-payer bill in the state of California would have saved $20 billion in the first year alone on administrative costs. And now we're talking about a $20 billion deficit that we have for if the Affordable Care Act is repealed. I think that that's a pretty good place for our legislators to start looking. And here's the thing. People are going to say we don't have money for it. We're already paying for health care. This was a study that came out just in August, a few months ago, by UCLA that showed of every healthcare dollar spent in the state of California, 70% of every healthcare dollar is already paid for by our taxes. So we're almost paying for everything already, coupled with the fact that the private insurance industry takes about 20 to 25 cents of every healthcare dollar away from actual patient care to use for marketing, overhead, administrative costs, and CEO salaries. So you put all that together, we're basically paying for a universal healthcare system, we're just not getting it. This was actually a study that then Santa Monica Council member Kevin McKeon had commissioned his finance chief to do, and when it looked like the Kuehl bill might pass, and they found that this would have saved Santa Monica $6 million in the first year alone. Finally, I just want to say that 58% of all Americans are in favor of a Medicare for All plan. 81% of all Democrats are in favor of Medicare for All plan. Thank you.
Thank you, Dr. Song, for your presentation. And I just want to let everyone know we have quorum now. And I think we need to recognize some of the health commissioners who've just come in.
Esparza, Griffith, Hisrich, Hawkes, Cotto, Mandel, Shannon,
Here.
Sharp, Vic. Here. 9 members present and a quorum.
Great, thank you. Okay, now I'd like to open this up to questions from the Health Commission. Commissioner Mandel.
I was interested when you talked about the bankruptcies due to, I guess, having your medical bills are too high, and that did not decrease after ACA was implemented. Why is that? Is it because the health insurance plans are not robust enough? What is the issue?
So it's actually a pretty sneaky way that the insurers do this. So particularly in the individual market, let's say you're shopping for a plan, you barely scratched enough money to get the cheapest plan there, which is the bronze plan. As you saw, the bronze plan has an average deductible about $5,000 or $6,000. So the majority of people, they don't necessarily have that kind of money sitting around. And let's say you're in an accident and you break your kneecap, and you end up in an orthopedic office, you spend a couple days in the hospital. That could easily be $5,000 or $6,000 that are necessarily out of your pocket, and insurance doesn't cover that. They only cover after the bill gets to $6,000. After you paid the $5,000, then they cover of that. So a couple things that the insurers have done, which is kind of sneaky. You go, let's say next year they raise your rates 15%, and you call Anthem Blue Cross and you say, I can't afford that. They're like, well, guess what? If you can keep your same monthly premium, but we're going to shift you from the silver plan that you had that only had like a $2,000 deductible to this bronze plan. So you'll pay the same each month, and you're like, good, I'm covered. And so a lot of people are not necessarily aware. They're looking at the short-term financial impact on their wallet. So that's probably the biggest reason that there's medical-related bankruptcies.
Okay.
It doesn't take much for the average household to go into bankruptcy.
Okay, Commissioner Mandel?
This turns on. Is it on?
Yes.
Yeah, thank you. First of all, it was a wonderful presentation, and I basically did a whole course of a semester in 30 minutes or so, 25 minutes, and I really appreciate that. Though there are points that are oftentimes mentioned that are debatable. So, for example, yes, it's true that 50 million Americans have a pre-existing condition. However, the kinds of pre-existing conditions that insurance companies would not write policies for, it's only 500,000. No, not to say that 500,000 nationwide isn't a significant number that we have to address, but it's a little bit of excessive rhetoric to say 50 million people. The other thing is about half of those people are insured by a government plan, Medicare or Medicaid nationwide. And so those people are eligible whether they have a pre-existing condition or 5 pre-existing conditions. So it really doesn't matter in that population. Second thing is you had this beautiful curve where there was a separation in costs that started around 1993, 94. The widest area of that and the dramatic aspect of the shift in that is actually from the SGR, where Congress again manipulated and created a inappropriate growth rate, which basically cost shifted all the rise in the cost of Medicare onto the small pay independent purchasers and independent purchasers and small businesses of America, and that's why you see the big growth. In regards to the single-payer difference between Canada and the United States, it's a true statement that the costs dramatically change, but there's 3 big aspects that aren't really addressed in that. One of which is that in the British system for tort, if you sue a hospital nurse or a physician, then the loser pays both sides. And so the amount of litigation that they have in the British system, whether it's in New Zealand or Australia, Canada, or the United Kingdom, is dramatically less. They have less cases filed. And with that also they have significantly less defensive medical practices. The difference of defensive medical practice here in the United States versus Canada is about $160 to $180 billion per year. So if we did institute a single-payer program here, our litigation system is different. We're going to have massive shortfalls, and we're not going to get the savings that some people articulate for the single-payer plan. The other thing there's a big difference is the Medi-Cal. As you know, probably 35% of people in the state of California have Medi-Cal. Medi-Cal pays differently and is matched differently across the country. So in some states, it's matched better than in California. California is actually hurt the most by Congress or by CMS or HHS's subdivisions. And so we get less coming back, even though we're sending it to Washington. That's a problem because every single time a Medicaid or Medi-Cal patient goes to a hospital or radiation oncologist, the reimbursement rate's going to be dramatically different. So, for example, in obstetrics, 10-month worth of care, in California pays about $880, and in Alabama it pays $2,880. And cost of doing business in Alabama is dramatically less. And, that's a big problem here, obviously. And so, if you did have a single-payer plan, the question is, what's the reimbursement rate? So the savings that we see on the Medicare slide that you showed so beautifully is somewhat artificial because the fixed costs of institutions, primarily hospitals and the like, you could take the physician costs or physical therapist costs totally out of it because there's only 18% totally of provider care. It's really what gets spent in the hospitals is the major costs. But if you look at that, the reason why Medicare is so efficient is Medicare underpays the fixed costs of those programs. And there's no solution to that if you have a single payer. In the last aspect of the single payer plan of current Supervisor Kuehl, when she was in the state Senate, in her plan, at least in that bill that got passed by both houses in our state, they divided the payer systems into 6 payment categories or areas, and LA County was considered to be one. But there's a big difference in the salaries of nurses, which are the primary cost of hospitals in California. If you go west of this building to east of this building or north of this building, so what happens is there's actually a 40% differential in what nurses get paid. So the problem that you'd have is that the west side of Los Angeles would be devastated because they'd be getting paid, the hospitals would be being paid for the same amount of service as, say, somebody that would be in Antelope Valley or Sylmar or far east in San Gabriel Valley. So you'd have a shortage of nurses because all of a sudden the hospitals couldn't pay the nurses that cost. There's a nationwide and California shortage of nurses anyway already. So though your articulation is
I'd like
excellent.
to really respond. I mean, it's
Yeah,
a
no,
long,
go ahead.
and I know.
So the point I'm saying is that we have to look at the complexities for this city,
Right.
Los Angeles City, as opposed to what's the best thing for the state or what's even best thing for the county of Los Angeles. As representatives who are defending the city of Los Angeles, we have to be very cautious of all the populations in LA City.
So let me just try to, off memory. So the first thing I will say is that study with regard to the pre-existing conditions just came out last week. It was a Kaiser Family Foundation. Medicare was not as part of that, and I will be happy to email that to you. That is actually the number. I was astounded by the number of people they defined as pre-existing conditions that could be thrown off health care under the potential things that were changed on the ACA. With regard to the tort issue, the reason there are lack of lawsuits in Canada is not so much because of, or I will say two things. The biggest cost of legal malpractice is the paying for consistent long-term care. It's covered in Canada if you are somebody that's been harmed by your doctor. With regard to states that have the most aggressive tort reform, Texas instituted the most aggressive tort reform. This is the argument that I think is completely been debunked. Texas instituted the most vigorous tort reform, and yet their utilization went through the roof. So the idea that doctors were practicing defensive medicine to prevent themselves from getting sued is not the case in Texas. If anything, it was the overutilization of procedures because many of them had self-referral systems, these Eurorads, where urologists own radiation oncology facilities, and they had the in-office exemption. So the number of tests that were done. Finally, the other thing is I used to practice at Cedars like you, where we did, the part of the reason I left Cedars is I saw patients there who would come in through the emergency room, have cancer, but because of their Medicaid, I couldn't treat them at Cedars. I had to refer them to California Hospital. As a physician that always took care of Medi-Cal patients, I know the reimbursement sucks. It does. But part of the reason that you talk about costs, Cedars chart overinflates, and they ridiculously overinflate. I've looked at some of that, I've questioned that, and part of that is because they're paying for the uncompensated care. If you now all of a sudden give everyone care and there is no such thing as uncompensated care anymore, they have no justification to keep the cost that high. Same other thing, because they become large and they buy up all of the existing practices, they can dictate and they can negotiate. Once you have one payer, guess what? You don't have all the cards anymore, and you can negotiate down rates. So why are they charging $27,000 for an appendectomy when St. John's is only charging, $15,000? Why? There's no justification, but they find ways to justify the price, and because they're the biggest name in town, they're able to keep those prices high. So you make some excellent points as far as nursing shortage and things like that. Again, hospitals are not hospitals like Cedars that enjoy. They can cherry pick the top paying customers to have networks with. But for the other hospitals, community hospitals that are living basically month to month or requiring state subsidies, once you know you have a steady stream of income, just like this uncompensated care, they're hiring more nurses. Part of the nursing shortage is, at least in California, is because a lot of the hospitals don't pay nurses a decent salary compared to what they do in other states. And then the last thing I would say about like a single payer system, I'm not saying a single payer system is a cure-all. I'm not saying it is without problems, but I'm saying the current system as we have right now is atrocious. It's inefficient, it's wasting, we're spending twice as much, and we still have 29 million people in the United States uninsured. I don't see how, you're an evidence-based physician. If you look at just data-based, how can you argue that if this was a treatment, would you continue on this treatment for a sick patient, or would you look at something that maybe not perfect, delivers more bang for the buck? I have no argument. Like, people say there are waiting lists and all those other things. I will just say, in the state of California, I've seen patients with private insurance who have waiting lists because you have to constantly get pre-authorizations to do things. My own father, when he was dying of cancer, I could go get him in to see a specialist right away because he had Medicare, and he didn't have to wait for some person to give him pre-authorization to go. We have, and I will say this, people who are on Medicare who have to have hip replacements, they actually get hip replacements done faster than people who have private insurance. So the argument that a government-run healthcare plan automatically will give you waiting lists compared to the private insurance industry is all of those things are. Look, I think it's a great debate, but I'm not saying one is better. You know, that one is 100% pure and pristine and without fault. But if you take a step back and you look at how is our state going to continue to meet the budget deficits that are there, how are we going to insure more people with a $20 billion looming cut? I don't think we can continue to raise taxes to just continue subsidizing an industry that only makes money by denying care. That's really what it comes down to. And the arguments that you posed, I think there's merit in some of them, but some of them I think are not been borne out. It's simply not the case. I mean, if you look at our healthcare system, the track record of our healthcare system, there's not a whole lot to say that to be proud of in terms of we're putting in so much money, we have so many uninsured, we have so many medical-related bankruptcies. I don't know how that is, good.
I'm not defending the current healthcare system. I'm just saying that when we look at it, if we have a responsibility as this commission to defend the people of Los Angeles, which is kind of what we're doing, that we have to have a healthy debate about some of the issues, and that, in fact, the demographics of our state are different than other states. And so the costs are different, but also the population is different. And so there's more cost shifts. The problem with the healthcare system primarily is the cost shifts. That's the reason why you have narrow networks. It's the reason why some states have a larger Medicaid population. As much as we might have an 18% cost to state budget, in Medicaid, in the state of New Jersey, it's 55%. So if we talk about problems of balancing their budget, they're going to have a much bigger problem than we are. I'm not defending the current system at all. I think there's problems with it. My point being that the alternatives have to be fiscally sound, no matter what they are, with the goal of high-quality care, access to care, and no delays. And unfortunately, because of the current system, Medi-Cal, as it currently pays, significantly less. There's a cost shift onto the small businesses and individual purchases of health care. Covered California basically bypasses that, but the only way they get around that is by having the narrow networks and the high deductibles and the bronze plans. And so we've created a total cost shift into the millennial population. So we've narrowed, unfortunately, the cost of health care by the ACA and elsewhere, so that for a guy who's 64, he's going to get a discount in buying his health insurance, and a man or woman who is under the age of 35 is going to have to pay 6 times as much. So as you know, with the ACA, there is an actuarial table of what the real cost of health care is, about 8.5 times different between someone who's 21 and someone who's 64. We've narrowed that down by law to 3. The reason why the millennial population is not signing up for the ACA is directly related to that, and it has to be addressed. But it was a hidden tax. So we just have to be honest when we have our debates about our goals are the same: high-quality care, access to care, and no waste, ideally. But you can't have hidden taxes that cost shift from one population to the other, because when you do that, the system falls apart.
Absolutely. But I think we all face hidden taxes every day by paying for the undocumented with higher costs one way or another when we access healthcare ourselves. And what I'm saying about a single-payer system is that if we pool all the money, let's just say if young people were able to buy into Medicare, everyone talks about Medicare being solvent. You now immediately spread out the risk pool, right? And maybe by doing so, you and then give Medicare its real ability to negotiate drug prices, to negotiate, well, you know, like when Kaiser uses its market share to negotiate drug prices, that's considered to be good free market business. But God forbid if Medicare tries to do that. You know, and I'm just saying if our state is going to simply just try to raise taxes or cut people off the rolls to make up for this deficit, to continue doing what we're doing, that I agree, Medicaid is not an effective system. We see patients, I look at them like, you presented with a tumor 6 months ago. How come you're just coming here now? And that's because it's not efficient. But if we did away with, again, all the systems and just had one single system that was the administrator of our health care, it certainly would make the average doctor's office much easier. You know, the average doctor's office spends $68,000 a year trying to get pre-authorization for their patients, either in terms of nurses being on the phone, doctors being on the phone, all those things. And part of it is you have a patient that you saw this year, then that patient switches jobs and starts a new job. Now your office is trying to track down what coverage is that patient be able to do. What a single-payer system is just doing is still keeping the private elements of our healthcare system. It's just taking over a multi-fragmented payment system to allow one person to administrate the cost. And whatever administrative savings are realized by that efficiency, pass that back on to insure more people or to keep premiums low. That's what I mentioned with the mergers. The reason all those big companies are merging is they recognize the cost benefit of an economy of scale, of reducing, from going from multi-payers to one big payer. They get better concessions from doctors and pharmaceutical companies and hospitals. At the same time, they have one metric for administrative system that's going to save money. But they're going to keep that money. They're not going to use that to expand healthcare for everyone else. That's going in the pockets of their shareholders. So that's really what all it is simplifying the back end, which is so complicated and so complex. That's it. And so if a doctor's hospital didn't have to distinguish between Medicare and and Aetna and Medicaid, and it was just one bill, think of how much easier that would save in terms of a doctor's office, a hospital, everything. It just makes that much easier. I don't see where that is not an ideological thing. That just makes common sense.
Okay, Commissioner Hisrich.
One thing, that's the first I've seen of Trump's plan. I didn't realize that there was something that was clear enough to put down. The only thing that's thus far occurred, as far as I understand, is an executive order to try to get rid of the mandate, the individual mandate. What effect do you think that alone will have? Because some of the other things are down the road, but there's that. And then the second thing is, I'm not quite sure where we go from here, because I think, I'm all in favor of moving toward have been for years, kind of a single-payer system or something resembling that. Where do we go in the near term to survive? Because I think things are going to get worse before they maybe get better.
So the issue of the individual mandate going away, I think, will cause a large percentage of the exchanges to kind of blow up, because a lot of the insurers, they're in exchange to take care of these people with those pre-existing conditions, we're banking on everyone buying in to spread out the risk pool. So I think the biggest thing that would happen is you would have a lot of insurers balk and pull out of exchanges and further reduce choices and competition that the exchanges were designed to do. So I think that's probably the most immediate thing. Where I lifted that off was a nonpartisan, that slide about Trump's plan was on a nonpartisan budget analysis person who was looking at the budget efforts that the Trump administration was already intimating that they would do. But as far as anything beyond that, everyone is just sort of waiting with bated breath to see what happens.
Yeah, the question of what Congress will or won't do is, I guess, still somewhat open.
Right.
We hope. Thank you.
Commissioner Jaquez.
Thank you so much for presentation. I have a completely different perspective. I work for Ultima, the largest FQHC in the country, and focusing on the health of our underserved, also in addition to our predominantly undocumented population, has been one of the cornerstones of what federally qualified healthcare centers do. During the duration of the ACA, our business has expanded up to meet the needs of at least 43%. In the whole 3 years expansion, we were able to increase job opportunities. We secured 1,000 employees during the process, and these are good paying jobs as well. We're really concerned, and I'm currently focusing on holding the line on the ACA just because of understanding the detriment to our community if you withdraw that healthcare system. Trying to figure out how do you address the issue, because the way we've seen the past 3 years, we've actually made our community a lot healthier. You no longer have, we have preventative services, we have situations where folks actually are diagnosed ahead of time so that they're not clogging the ER systems with, now they're going into having amputations because you find out they're diabetic, and so on, costing taxpayers additional money. So it's a matter of how do you preserve this, and we understand it's not perfect, but how do we continue to move forward to continue to protect our most vulnerable?
Thank you. So I'm on the board of the Eisner Pediatric, so I know what you all do and admire it. And we've certainly seen the same type of thing with the ability to cover much more marginalized, disadvantaged communities of color and are undocumented, and it's been a big boon. We've been able to hire a lot more people. We were the first group to announce that we're giving minimum wage to all our employees, raising the minimum wage to 15 because we were able to do that. So look, the first immediate step, so tomorrow we're sending a busload of about 1,000 people up to Kevin McCarthy's office to protest to preserve the ACA, because in his district alone, 77,000 people who are on Medicaid stand the chance of losing coverage if he just repeals that. So our first step, obviously, is to still fight to maintain and preserve the ACA. You're starting to see some Democratic senators, Republican senators propose allowing states to stay in the current ACA or opt out. So it's sort of in between what the real right is trying to do and what is existing. So listen, if that happens, we'll fight hard for that. We are fighting hard for that. But what we want to do is just say that even if we get that, it doesn't go far enough, and we need to even give more. I think there's no reason why our undocumented brothers and sisters should have an inferior plan, and I'm sorry, Medi-Cal is inferior, even with the efficiencies that people have started to bring into it. So yes, we're focusing until we know for sure that it's absolutely not going to be saved from a repeal. We're all working really hard for that.
Interesting. I want to get your perspective. We're starting to hear different proposals about just block granting it, which we have issues with. I mean, wanted to get your perspective on that alternative.
So that one graph that I showed you, the issue of block granting, and remember the way it was supposed to work was for the next several years we were supposed to get 90% of every, for Medicaid instead of a 50-50 split. But they found with block granting, it's going to start, the deficit's going to grow. It's kind of like the privatization of Medicare when they give seniors a voucher. You saw how private insurance industry controls prices compared to Medicare. Pretty soon, the voucher's not going to meet the share of the actual increase in cost each year. So that is the concern with the block grant. The block grant is not going to be enough. As you all know, California already has a hard time meeting its Medicaid obligation as is. So a block grant is really going to sell it short. And Howard said something really right on was, we're a donor state. We give far more to the federal government than what we receive. And some of these red states, they get sometimes 60 or 65 cents of every Medicaid dollar, and they only have to put in 30 cents, whereas we have to put in 50 and 50. And so it would be interesting if we're really going to get there for our legislators to demand we get the same as Louisiana or Mississippi or something like that.
Thank you.
So for ultimate, or for your population, you would actually, the way the block grant is proposed in the Cassidy-Sessions bill, you would actually, your population would actually benefit greatly because you wouldn't have to do any billing, and they would give it would be more of a per capita. So you'd be basically getting a block directly to your whole system. What might lose out are more hospitals, but they have a safety net, kind of like the DISH program. Built into the block grant, there's a safety net where money would go back to the community and just be dispersed to hospitals, kind of like DISH would be. But big federally qualified health centers would actually benefit. What we might lose out are institutions or hospitals are maybe not as efficient as you guys are. But places like you would actually win because you wouldn't have to do all the administrative billing that you're doing on a regular basis.
Because that was a huge part, right? With the realignment that happened in California, a lot of these community centers started to lose funding from the state, and it was the federal government through the ACA that really was able to make that up and make it better. But so I can assure you, the single payer thing is sort of the back step, but the immediate step is to try to protect what we're doing. Yeah.
Thank you so much. Thank you both.
So I'll take chair's privilege for the next question. So I'm just wondering, is there legislation that's being put in right now for the state government for single-payer health care?
So there's a big coalition of labor, community activists, and other groups that are meeting with several legislators right now who are very interested in potentially doing that. Sheila Kuehl was quoted at a Christmas party over the holidays saying that she knew of 2 senators who were very interested in resurrecting her bill. But I certainly don't think it would happen under this governor. He's been very reticent against anything like that. But that's ultimately the plan in the next 2 years, to either get a bill introduced or to go the legislative route.
So if there was a repeal of the ACA, and I'm very concerned about people who are in Medi-Cal. My clients tend to be homeless, and a lot of them were able to get onto the ACA through Medi-Cal, where before, because they didn't have children, they weren't eligible. So what would you, do you anticipate a gap, a time gap in terms of where people are not covered under Medi-Cal because of an ACA repeal?
So that's where everyone is scrambling right now. Certainly the fiscal budget for the next year has already more than, it's not clear that the cuts would come immediately, because remember, people just signed up for re-enrollment in the exchanges, so they're certainly going to be covered through 2017, and the federal government has to meet the obligations for that. But for 2018, it's really not clear, and that's where we're all just, wringing our hands, kind of worried what's going to happen.
So if legislation were put through this year, or even next year, is it possible that there wouldn't be a gap, or are we
you mean a single-payer legislation?
There would be either single-payer or any other solution?
So I think, well, the immediate thing would be to raise taxes to meet that shortfall, the potential $20 billion, right? But it would take 2/3 majority of the legislature, and then, but that would be probably the quickest way to ensure that whatever the federal government did, we could continue providing the coverage that we have right now. That's the shortest, but realistically, I'm not sure how we just had some other big increases, on the propositions and the tobacco tax. I don't think the appetite is necessarily there, and it would be a 25% tax increase that would be required to make the $20 billion shortfall.
Any other questions?
Yes, I have one very brief question.
Commissioner Sharp.
Thank you. What can the City Health Commission do, which is a province of the City of Los Angeles? Is there a specific strategy that the city could take, for example, as an employer of 40,000 plus Angelinos, as a planning and land use agent that interfaces with lots of medical facilities? What recommendations do you have for the city, in addition to what I hear implicit in your remarks, which is endorsing of various state and federal legislative policy changes to be materialized? What could the city do?
It's a good question. I think you, as a commission, could certainly make a recommendation that if there is talk to raise taxes that dramatically, that certainly it not just be blindly used for the status quo, that certainly all other systems be considered, or other alternatives. Certainly, I think we have some very smart people in this room, as well as in the state, that could come together. I think the biggest thing I'm concerned about, though, is that 4 million people, the state will say, well, we can't raise taxes, and we're going to go back to like we did during the budget deficits, where we just decimated health and human services, that's not an acceptable option, that we have to find something else. That if we can't raise $20 billion to meet that offset, perhaps we should look at a single-payer plan that's been shown in so the Lewin Group, a nonpartisan group, Lewin Group did a study back in 2008 that showed in the first year you'd save $20 billion, which is kind of ironic that that's the amount that we're talking about now. And that was in 2008 dollars. it certainly could be greater now.
Okay, Commissioner Cotto.
Yeah, can you say something more about what when I think about creating a new payer system, that's a very complicated. I think of that as a very complicated process. So I get in principle that if one were to establish it, then one could get these benefits. But are there examples where a regional, particularly a governmental entity, has been able to create in short order a payer structure like that?
So, Taiwan instituted a single payer system in 1 year, and their population, I think, is greater than the population of the state of California. The first year had some hiccups, but they were by and large able to do it. Now they have the most modern EMR, electronic medical record system. They have a system with a card where if you go anywhere in the country, they swipe it and all your medical records come up and they show you what medications and everything you're on. It's possible. Now, it might be hard to do it on a federal level, and certainly one of the things you'll hear from people, well, Vermont tried it and it failed. Well, Vermont only has a population of 500,000. So, and if you take into account the number of people in Vermont that were on TRICARE, which is the military health care, or things where they could not get the exemption or the waiver, then the risk pool wasn't great. It's too small of a jurisdiction. You take 33 million people, it's a whole different ballgame. We're roughly the size of Canada in terms of the populations. Canada maybe I think has 2 or 3 million less than we do. But it's very possible. Taiwan did it in a year.
Any other questions? Thank you so much for coming.
Thank
Really
you, guys.
appreciate that. Wonderful PowerPoint. Okay, we'll move now to public comment. Mr. Herman.
Maybe what most people don't understand and will never understand is that such a lengthy presentation doesn't give us any hope. There's no hope, because if there was a solution to hope, none of us would be talking about Medi-Cal, Medicare, who gets benefits, who does not, the do's and the do-nots. I happen to have the do's and the do-nots. But because I'm able to have both type of premium insurance from that of a company or the employer, fuck them. And then on the outside, the state of California gives me my little white placard card that you fools that have a job pay for. I'm able to get full coverage insurance. And I should, because I'm a citizen. You've taken away from the citizens as pimps, poverty pimps that you've become. And am I ashamed of myself for saying it? Hell no. Because some dumb motherfuckers can stand in here and look me in the face and say, we're going to take care of it for you. Well, no one's done a goddamn fucking thing for me. I had to do it on my own. Fight for my fucking insurance. So don't stand in here saying this is the way to go, this is the possibility. It's all a bunch of bullshit. A sham. A bunch of schwugs that don't really want to do a fucking job for the people that you're supposed to serve. Americans. People who live and work in this fucking country that you stole from. Stop fucking stealing and provide a real service under ADA Title I and Title II.
Thank you. Mr. Spindler?
Go ahead and start as 1 minute for general public comment. Yes, Mr. Marquis Harris Dawson?
Doing a meeting and speaking far past their time.
I understand that, but I was just reminding him that shouting into the microphone does not help.
And the speaker is now disrupting the meeting.
Sir, you're disrupting the meeting. The clock is ticking, sir. Your minute is ticking.
speaker should address his comments to the president or the committee.
Dumb fuck. Now shut up when I'm talking. That's rule number 1. I want a federal lawsuit. And so shut the fuck up. I'm talking here. Now we got a real problem in the city, you dumb fuck. You sat here and ignored your duty and you got homeless encampments all on the fucking sidewalk. You can't walk down the street. You're sitting here doing fucking more luxury condos. You're patting yourself on the back about Olympics. You're taking payola from the Dodgers. What the fuck is wrong with you people? You're mad people. Hey! I've asked you not to shout into the microphone. Thank you very much, sir. Your time is over. You're disrupting
See, that's what happens when you come here Tuesdays, Wednesdays, and Fridays that speak the truth. Men with guns, threats, intimidation. That's what is really happening. And you guys are going to go ask for more money. More money? You stole $17 billion already from the city's treasury. And you want more money? You want more money. When you turn around and have Rick Caruso buy our city council and you sit in those chain chairs, now felony indictment in the making, and you guys want more money. Now, Trump won the election. It's time to defund and bankrupt this disgusting fucking place.
Okay, moving on to item number 2, we have a presentation by Beth Steckler, who's the Deputy Director of Move LA, on a discussion and/or action to support countywide sales tax increase for homeless services under Measure H. Actually, you can come to the table.
Good evening. Thank you for the opportunity to talk to you about a really, really important measure, Measure H, on the March 7th ballot. Measure H is called the LA County Plan to Prevent and Combat Homelessness. It is a plan to fund LA County's comprehensive plan to end homelessness. It's I don't know what to say. I used to run a shelter in San Pedro in the mid-'90s, and so I've seen how the homeless policies have not really kind of gotten us anywhere, right? The numbers of homeless keep increasing. We have 47,000 homeless people in the county right now as of last year, and the count's happening now. And this is the first time that we have seen a plan of the scope to deal with the problem. So the county went through a process of looking at the homeless situation and the strategies that we had been using to address it. This was in 2015. Phil Ansell over at the county executive office put together a homeless initiative. And they had 18 policy summits. Some of you may have been involved in some of these, on 9 different topics. Over 100 organizations participated, 30 cities, 25 departments. It was really a thoughtful process. And out of that came 47 strategies that the county would like to pursue in order to end homelessness in LA County. Measure H is how we're going to pay for that. So Measure H raises $355 million per year for 10 years. So it's a time-limited, it's a quarter-cent sales tax increase, temporary sales tax. And it would be used to fund, services to get homeless people off the street across the county. The money would go out based on homeless count. So we do a homeless count, and we see where the homeless people are, and the money would go out to fund services in those areas where we have homeless populations, which is all over the county, but of course larger concentrations in different areas. The system is a partnership between the county and the city and nonprofits. Not just the city of LA, but also the city, all the other cities in the county. You guys were probably supportive of Measure HHH, which is going to fund 10,000 units of permanent supportive housing in the city of Los Angeles. So that is all bricks and mortar money. So the supportive in permanent supportive housing is for services. This measure is about those service dollars and much more, because it also includes other cities, and it also includes the services to get people off the street, outreach services, mental health services, and also to stabilize people, once they come off the street and need services afterwards. So not everybody needs mental health services for years and years. Some people just need help getting into an apartment, and then they're going to be fine, right? So it really is about the success that we've had. Like with veterans, we've had amazing success with veterans because we've focused on that population, and we've been able to bring the homeless population way down among veterans. We're not done yet, but we know we have, like, I have some stories here. One of Tyrone, who this agency, PATH, you might be familiar with PATH, helped. He was a Marine veteran. He had been homeless on the street for 34 years. He was a veteran in Vietnam. So he probably, I worked downtown, I probably passed him many, many times. Looks like someone who cannot be approached. But indeed, people have approached him, got him some services, and now he has an apartment. And this individualized approach is really what this is about. And doing it through the nonprofits that are successful, as well as the county agencies and the city agencies that can help. We have really broad support for Measure H. United Way is one leading organization that is supporting. There's a large number of social service providers, which we would expect. But also, we've got great support from the business community. The LA Area Chamber of Commerce, which has been very involved in homeless issues, working with United Way and their Home for Good program. We also have the LA Business Council. Today, VICA endorsed, which is really a great testament to their concern about homeless in San Fernando Valley. And BizFed endorsed last week as well. So the business community gets it, that we're not dealing with homeless people in an economically efficient or successful way right now. So the business community is in support. We have a lot of leading labor organizations and religious organizations as well. So I'm here to answer any questions you might have, and I passed out a flyer and our endorsement sheet as of a couple of days ago.
Great. We'll open this up to questions from our commissioners.
Could I ask, what is the entity which will be administering the funds that would be created by the action?
The County Board of Supervisors. So if you look at the homeless initiative there's a homeless initiative website, you'll see the 47 strategies, and it has identified who are the entities that would be implementing it. The county will do an allocation plan every year. There'll be a process leading up to the first year, because the first one will happen at the end of June. So they'll do an allocation plan every year. There's a citizen oversight committee that will be looking at and putting out annual reports, and there'll be annual audits. So there's some flexibility built into it. I think about, if we're pretty successful in getting veterans housed, the services might shift a bit, as we reach success, but it's a 10-year measure, right? So the flexibility, the final decisions rest with the County Board of Supervisors, but it must be spent on homeless services. It is a special tax. So it can only be spent on homeless services and housing.
Okay, any other questions? Commissioner Hawkes?
Just so I'm clear, so this proposition will work in conjunction with HHH, so both city and county will be working together in the collective? Great. And then what is the support you've received as far as LA City, the mayor, and LA County?
Well, LA County, the vote was, well first, on the cities. The county's starting a process to do memorandums of understanding. So there will be an MOU that talks about the HHH units, but as well with other cities, because not everyone has HHH, right? At the County Board of Supervisors, the vote on December 6th was unanimous. So all 5 county supervisors support it. I'm forgetting the name of the city council committee that takes rules committee in the city has recommended yes position for the city of LA. A lot of the planning that happened a year and a half ago involved the city and the county really working together for the first time, and we were expecting to have something like Measure H on the ballot in November, and it just didn't happen. So we fully expect the city of LA to pass this, to endorse this without a problem.
Thank you. That's always been my issue, is making sure that these continued efforts aren't done in silos. And so it's good to know that you're working in conjunction with each other. How does this affect the housing authorities?
Housing authorities are part of it. Okay. I mean, it's amazing if you look at those 47 strategies, and because the housing authorities have both vouchers, but they also have apartments that they own, right? So there's a lot of resources there, and it's been the fracturing of that is part of what's not worked. So we've spent a number of years trying to understand the program and doing little test pilots to try this, to try that. And I think people are pretty clear that we're at a place where we know what to do. We've got the capacity to do it in terms of expertise. We're just not at the scale we need to be. So I feel like, from my perspective, having been engaged in this since the mid-90s, that the stars are aligning, that this is an amazing opportunity here. And it may not happen again. We're very, very hopeful that we can get the 2/3 vote that we need. But I think it's an extraordinary situation that we've seen this much cooperation. And part of that is success breeds success, right? HHH is successful, and then, people feel more positive about the county doing services. So.
Thank you.
Sure.
Commissioner Sharp.
Just like my fellow commissioners, to consider a motion in taking a position publicly in support of Measure H.
So I have one more question, actually, and then if that's okay, we'll go for a second. So this commission has been very supportive of the county's Housing for Health program, and so I'm wondering if you know if any of this portion of money that will be raised through Prop H will go to Housing for Health, which is also a housing program within the county for people who are homeless and chronically homeless with underlying medical conditions.
I'm sorry to say I'm not familiar with that program, so I can't really answer the question. But I do feel confident because the county has taken the time to look at everything and try to make it work together. One of the uncertainties around it is as the Medicaid waivers that we've gotten now around this may somehow be in danger, but we'll just have to take that as it comes.
Okay, so great. So a motion has been made to support Prop H and seconded. Any discussion? Okay, can we? Okay, the motion was made by Commissioner Sharp. Seconded by Commissioner Mandel. Okay, all in favor of supporting Prop H? I think we can just do a voice vote. Please say aye.
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 Any opposition? Any abstentions? Great, thank you so much.
Thank you.
Great, thank you, and good luck tomorrow.
Vote on March 7th.
Thank you. Okay, now we'll move to public comment. Okay, Mr. Herman?
Usually you vote after public comment.
The meeting.
We can take the vote.
Sir, you're disrupting the meeting. The clock is ticking, sir. Your minute is ticking.
Suit ain't working for you, bro.
The speaker should address his comments to the president or the committee.
Dumb fuck. Now shut up when I'm talking. That's rule number.
Rule number one. Rule number one regarding Hilda Herb Hitler. HHH. Item 13 for the record, 16/1060/S1. Wednesday. No, this will be for Friday's public comment. Let's see if one of you have the nerve to show up that Friday and back up HHH. Hilda Herb Hitler. Because after all, it is a proposition for homelessness reduction and prevention. 47,000 goddamn people sleeping on the sidewalk and streets. You find them as you walk away from City Hall in the dark, like I did last night after we talked about the strategy of illegal immigrants. Trump is going to make not your world better, but those of us who are Americans that stand up for the lives of all Americans. What are those veterans fighting for? Or what were they fighting for in those other countries? To see HHH living on our streets? Was that the purpose? Is that the purpose? Because it's a hell of a poor excuse to see thousands of people homeless in the United States, while poverty pimps make up bullshit rules and laws like Herb Weston Jr. and persecute people who live on the street. Shame on your goddamn ass, you fucking white caucus nigger.
Mr. Spindler?
And look who's backing it. Major funding by Mark Ridley Thomas Committee for a Better LA. Where'd he get that money from? How about last night's little party, $2 million to go to fund illegal immigrant representation with a promise of $3 million from the county? Where's the other $5 million going to come from to make the $10 million? Campaign donations, contributions from so-called philanthropists. Absolute money laundering scam and scheme to raise the sales taxes, to take money and waste it and give it to your friends. This bullshit is money laundering. That's all it is money laundering. You got a guy that doesn't do enough, he doesn't get paid enough, Mark Ridley Thomas, or he's got to raise money from his campaign donor friends to support and funnel and defraud all of us for a quarter-cent additional sales tax on an outrageous level of sales taxation, which is a regressive tax. It hurts the poorest in Angelino. You don't give a shit about that. What you care about are your private parking spaces and your leased cars and your trips and your parties and your rewards and your retirement benefits. So while you do all that, the poor of the city get poorer. Nobody, not a single veteran, gets one apartment to live in. It's just a money laundering scheme. And the time has come for a decision to be made. I say let's pay some people to leave this fucking place. 2 federal lawsuits.
Thank you. Commissioners, we did take that vote out of turn, so I'm going to ask Commissioner Sharp to make that motion again, and we can entertain our vote.
Move that the Health Commission take a position in support of countywide Measure H for the March 7th ballot.
Okay, so it's been moved by Commissioner Sharp for supportive position on Measure H and seconded by Commissioner Mandel.
Is this to recommend to the council that they support it? Because I don't know whether we as a commission do it or we recommend to the council to do it.
So we as a commission can do it, and we can also recommend to the council.
Okay.
I don't think the commission can do it itself because it's supposed to be making a recommendation to the city council. So I think you can only make recommendation to the city council and the mayor to take to support this.
Okay, do you want to change your motion?
Thank you for the clarification, City Attorney Lee. So I propose substitute motion that the Health Commission recommend that the Los Angeles City Council adopt a position in favor of countywide ballot measure H for March 7th.
Okay, can I just rule the first motion out of order so it's not a substitute? We can just take this as a main motion? Yes. Okay, great. So it's been moved and seconded, moved by Commissioner Sharp, seconded by Commissioner Mandel to support Proposition H. Any discussion? Okay, we could do this by voice vote again. All in favor, please say aye.
Aye.
Any opposition? Any abstentions? Okay, thank you. Okay, so now we will move on to item number 3, which is a discussion and or action on Health Commission priorities for 2017. So would anyone like to start that discussion? Okay, Commissioner Vick.
I came across maybe a month or so ago some disturbing information regarding equitable food access. There is and this is very specific to Council District 8, but I believe it could be applicable to other parts of the city. There is a grocery store that has deplorable conditions and has had them for a number of years, and there has been no effort to resolve it. So I'm just wondering if there is some need to look at this more closely, both in that council district and other parts of the city. Are grocery stores or where people get their food up to code, safe, clean? So just really thinking about that as an issue, food access.
Great, thank you. Any other comments? Commissioner Jaquez?
Yes, I'd like to follow and eventually have the commission make a recommendation on the ACA and what has direct impact to the city residents as well as the county. So we can continue to follow the ACA.
Great. Any other comments? Commissioner Sharp?
A couple comments and a request for our stakeholders who are gathered in attendance to provide input regarding this agenda item. We're eager to hear what we might do that you believe would be helpful. I guess my view is that the duties prescribed in the ordinance setting this up have not been met. They're very complex. There are no staff to do a number of the functions, such as auditing county contracts, attending a lot of meetings. We're out of alignment with that, and I think we could realign with some other things like the 2 topics that we've mentioned so far that are of relevance and of interest to people here in the building. And I think we ought to my suggestion would be that we formalize a request both to get staff to be able to actually get into the level of depth and engagement with other parts of government that would be needed to actually accomplish both the stated requirements, duties, and any others. So that would sort of be priority number 1, to actually make a formal budget request that the city at least in part fund this or seek philanthropic support. And then the other major priority would be to actually ask what the needs are from a variety of points of view. We've heard from a number of persons that folks around the table have contact with that have informed and I think created lively discussions. I think there may be a way to actually solicit from city leaders and or county leaders what are the current challenges that this particular assembled body of experts with different experiences could provide insight on to make us more useful to them and potentially inform policy discussions. I can think of 4 or 5 major health decisions that the city council made last year that this commission did not contribute to, and I would like us to use our time in a way that at least contributes and potentially informs and shapes some of the decisions that are forthcoming that we may not be aware of. I certainly won't be aware of until I read about them in the LA Times. And I would suggest that that would be sort of a second priority, is actually soliciting the priorities of city leadership, which would, I guess, be mayor, attorney, controller, and city council, to help inform this. And then the third priority would be to engage with the entity that is assigned to do the county oversight within the county government, which is called the Integrated Advisory Board. Right around the time this was convened, the county set up a citizen commission of similar makeup to provide oversight of the consolidation of 3 county health departments into one health agency. They have been meeting, studiously proceeding to both look deeply into how county functions, coordination, cooperation. My third priority suggestion would be that we figure out a way to either co-convene with them or invite a representative to give a summary of what they've been doing, so we can at least at some level claim that we've attempted to figure out how to provide the county oversight function that's prescribed in the ordinance, which I believe is impossible to meet without a significant staffing level that we don't see on the horizon for 2017. So those would be my suggestions for consideration for the, I guess, the year ahead.
Okay, great. Any other comments?
I just wanted to say that perhaps we should invite Dr. Katz back, because he's heading up the agency, and currently they're having a lot of discussions around the consolidation of mental health services, and public health. And I think it, would be one of the important things that we can do, because it does involve the city as well as the county in the planning that they're doing.
Okay, any other comments?
Yes, we are worried about accessibility to insurance for people, the rising cost. But in the Plan for a Healthy LA, in the guiding principles, it's looking towards promoting health and wellness activities for Angelenos so that these health care costs could come down. And we have a great plan, and yet it's stuck at the point of where and how and when to implement it. As a commission next year, I'd like to be able to look at different things where we could give recommendations, specific recommendations within that Plan for a Healthy LA for the council to start looking to implement. I've attended a few of the council health, mental health, and education committee meetings, but it seems that the Plan for a Healthy LA still is something that was developed, but not yet to the point of implementation. So I'd like to be able to make recommendations during this year for implementation of that plan.
Okay, great. Any other comments? Commissioner Jaquez?
I wanted to piggyback on Commissioner Sharp's points. I think it's definitely maybe a subcommittee to focus on making sure we're in line with what we're supposed to do. So that'd be paramount. The second issue is there has to be some kind of structure so that we're following the health committee, so that we know what's going on, so we can make recommendations to them prior to them actually voting. So it's not for an ad hoc situation. It's more structured, that we know which items are going to come up before the Commission on Health-Related Policy. So is there a way that we can figure that out so that we can make recommendations prior to council decisions on health-related issues?
Yeah, so I can answer that just briefly. So typically, I will find out about something about 24 hours before it comes up at the Health Committee, and that's just a matter of them not communicating with us what's happening or asking us to come and give a presentation or to be present when something's coming up. So I'm hoping that there'll be better communication between the committee and the commission. I think now that we have our first report behind us, I think that given the fact that last year was our first year of really doing this and people were just trying to figure out like how this body would work and communicate with the various committees within the city of LA. I think now that we're past our first report, I think that now we can sort of move forward. And we sort of have a bit of a structure here too within our commission in terms of work groups and sort of how we're going to move forward. So I think moving forward it'll be easy. I think last year was difficult just because it was our first year, and there were challenges like where we were going to get money to do the report and to have staff and that kind of thing, that we were sort of working through the nuts and bolts of that. So I think moving forward, I think we can be more focused, and hopefully there'll be better communication between the committee and the commission.
Just mentioned about the report, but can we get an update on the status of the report? Because I don't think any of the council people have received it.
The report's here.
They have, but
yes,
I asked the legislative director for Councilman Root, who is the chair for the health, about whether he had received the report. And
yeah, all the reports were distributed tonight. I know that you came a little late.
Okay.
So all the reports were distributed tonight to the various commission members, and tomorrow morning will be distributed to council members.
Okay.
And then hopefully we'll be getting the PDF file up on our website, and that way people can access it from all over the city. And also a copy will be given to each of the members of the institute from California State University Northridge who worked on it. So we have actual physical copies for each office, all of our commissioners, and all of the people who worked on it. And then the PDF file can be forwarded, and as soon as we get the link up on our website, I'll send that out to all the commissioners, or the city clerk will, so that you can forward that on.
Have we presented it to the council, or is that something where?
Yes, so we are.
So we
So
can
that
get
is
feedback on what, if this is what they wanted, if they want us to look at other things, it'd be good to get feedback from them so we can go ahead and move forward.
Yeah, so we'll be giving a formal presentation to the council, and they're looking right now at when we'll be agendized for that. Any other comments or questions? Okay, so we'll take public comment, and then if you want to make a motion to create a subcommittee. Okay, now go to public comment. Adam Cohen with AIDS Healthcare Foundation.
Good evening. My name is Adam Cohen. I'm the Director of Advocacy and Policy Research for AIDS Healthcare Foundation. Congratulations on finishing the report. I had a chance to not peruse it in depth, but I got to take a look at it, and it's very compact, so the issues are addressed very straightforwardly, which is a nice read compared to the 200 plus pages of the CDC's Std Report that came out last month that I had to read the entirety of. One quick comment I did want to make: I really enjoyed the first speaker's conversation about rising costs, and I think that this commission is going to be more important than ever now that we have a certain person in the Oval Office. And it's not that America has the best health care, but we do have the most health care, as one of my professors once told me. I would love, because this report that the Health Commission put together doesn't include STIs and HIV, to, for the future, definitely address this issue, because based on the CDC's STD report that came out for data on 2015, yes, for 2015, LA County, once again, it has the highest, is up in the top, essentially, for all serious STDs, which include chlamydia, gonorrhea, syphilis, and HIV. And this is especially disconcerting because more and more studies coming out, not only about drug-resistant gonorrhea, but drug-resistant syphilis as well. So, again, great job. I look forward to how the LA City Council will receive the report, and I hope that they take it to heart and say this is a commission that's worth moving forward and receiving the respect it needs. Health is going to be the topic of issue for the next 4 years, like no question about it. Thank you.
Mr. Herman.
The critic is back. The critic from Los Angeles is going to talk about the supporters, those like St. Anne's and St. Joseph Centers. Action to support countrywide sales tax. But you know you're going to say no, fools. On Measure S, you're going to say yes. That's not part of the topic, though, fool. Because the real issue here, when I talk about St. Joseph and St. Anne's, I talk about St. Salesian High School. You heard of St. Salesian High School? It's right down the street in Boyle Heights. Some poverty pimp, white nigger named Jose Weezer fuck with a gentleman from down there named Herman. Crazy motherfucker from Boyle Heights. You don't fuck with people in Boyle Heights. Because we're supporters, fool. Real supporters of what real supports do. When it comes to sanctuary cities, and we say no to sales tax because of the goddamn issues of homelessness. That gentleman that spoke on item 1 and 2 was talking about homelessness. And you fools sit there looking at this podium like it's somebody. I'm just a puppet. A goddamn real puppet that has a mouth and 2 eyes on top of my 4 eyes. But let's go back to topic. Let me read it for the record. That the following persons of the Citizens Oversight Committee of Proposition HHH, the Homelessness Reduction Prevention Code Section 8327, and the term expiration dates indicated, item 13, 16, 1060 S1, Hilda Herb Hitler, HHH, Friday, in this chamber, Friday, the 27th of 2017.
Thank you. Mr. Spindler?
So what do we have here? While my friend was speaking, I read a bunch of poverty pimps on a paper that was given. The Downtown Women's Center. Where were they? Went right in this building. Francine Godoy was going, ah! Yes, being accosted by Jose Weezer right here. Where was the Women's Center when right here our mayor was cavorting with the president of the Public Works Commission while her daughter was down in the garage going, Mommy! Mommy! Where are you? I'm up here with the mayor. Mommy! I'm up here with the mayor. I'm doing some coke and having sex. Don't worry, little child. Find a detective and get back up here. And of course, nobody investigated the child abuse. No, not you people. And then we have FAST, fixing Angelinos stuck in traffic. Well, look out there in the traffic. Are they being fast out there? The traffic is worse. So, 501c3, Mr. Trump, pull their fucking certificates now. Revoke all of these 501c3 exemptions now, immediately. These fuckers don't do what they say. They are only there to funnel money from the politicians to the developers, back to the politicians, and back to the nonprofits, and then back to the sales tax. HHH, bitch, bitch, bitch. HHH, Hitler, Hilda, and Herb, the 3 worst things in life.
Okay, thank you. Moving on to item number 4. We'll move. Actually, are there any motions that anyone would like to make regarding item number 3?
Yes. And I want to acknowledge and commend Commission President Shannon for getting us in line with taking public comment before we take action, right?
Thank you.
We're going to get that right from now on. Yes, I'd love to make a motion, or at least entertain or hear others' motions regarding adopting and communicating a handful of priorities for the year that we could disseminate and share in order to get the right sort of input and the right sort of speakers scheduled over the course of the year so it's clear what we're doing. I proposed, 4. I heard several others that were great, and I would love to see a motion that somehow solidifies that so there's sort of a specific set of things that we're committed to doing.
So if I could take chair's privilege for a moment. So we do have established working groups. So when we're talking about food deserts and that kind of thing, I think that's, that could be moved under healthy living because we did deal with some of those issues in our report this year. And then for STDs and AIDS, which AIDS Healthcare Foundation brought up, we could put that under medical services if people thought that was appropriate. This year for our report, we did talk about Zika virus and meningitis and did put that under our medical services work group. So if people felt that that was appropriate, I do think, as Commissioner Jaquez mentioned, that I think it's important to create a subcommittee to deal with a lot of Commissioner Sharp's great recommendations in terms of keeping us in line in terms of the ordinance. So maybe we could just have maybe one motion to create that subcommittee and move some of these issues under the other subcommittees would be my recommendation.
I think my experience was that we struggled to convene the working groups and the subcommittees over the course of the year. There were a handful of people that did most of the writing in the report, and I'm sort of proposing a slightly different approach this coming year, which is that the majority of the work occur here in the commission. We have a few deliberative issues that come in front of us, and that we try and resolve as much of it as we can in these particular meetings of the whole. I think that it is great to imagine that there's some of these specific subject areas where a small group would convene a call to get into greater depth. The priorities that I was proposing we approach, I don't think are resolved within the current working group. They're resolved by sort of saying publicly, here's our priorities, pushing that out there and seeing what comes back, and then scheduling a few things over the, I don't know, next 3 or 4 or 5 months to occur in the committee of the whole. Because I think the chemistry of 8, 10, 12 people is much more likely to inform me regarding the discussion that leads to the right kind of recommendation than a small group which struggles a lot with scheduling to do a phone call of 2 or 3. So my suggestion would be to try and adopt some priorities that would be for the whole commission. And if at some point there's a few people that pull off to try and develop more detail, that's great, but I'm proposing a slightly different approach than breaking it off into the working groups, just based on my experience last year.
Commissioner Mandel.
So are we allowed by law, City Attorney, to get information sent to us first so that we could be more intelligent to have a conversation or a discussion between 8 or 10 people?
The clerk is permitted to send us information. We just can't email back and forth to all of each other.
Okay. So I would say I would support what you're advocating as long as there might be areas that we're not knowledgeable about, and that if we're pointed in the right direction to do some homework beforehand, the discussion is going to be much more lively as well as more informative to the city.
Yeah, I would say the mechanics, though, of actually writing out the report and the various sections of the report do require some discussion, and it just, I felt that it made it much easier by breaking out into work groups and being able to discuss with people who either were sort of experts in that field or had a particular interest in it. And it just made it, just to get to the final report, it just made it much easier, I thought, to be able to have these sort of conversations in work groups as opposed to a whole group of people, who will be here, fairly late if we're just discussing each and every one of these breakout issues. So I just think I would advise against that. I mean, I think it's fine to do things in a committee of the whole, and we can decide which specific issues we want to bring up. But I think it would greatly probably diminish the size of our report and the number of issues that we can
I
take
agree.
up.
I think that's better.
It could also, okay, if I could finish, please. And so it would diminish that, and it would also, I think, prevent us from being able to talk on a regular basis about these issues within these smaller groups, since we can only take up so much during our actual committee of the whole.
This is Commissioner Vick. Is it possible to do both? Some sort of way create a hybrid situation where maybe the bigger, broader picture ideas are discussed and outlined here. And if there is need that it is broken up, but I do think it is important to kind of have some of that work done here because we're here. So maybe there is a way to get to a middle ground.
I'd add to that what I heard as some ideas, some areas to focus on, they're all, they're each of merit. Some of them, as you say, could flow right into working groups that we have. Others of them, we probably need to distill more what they are, how deep we should go. And so that would be something where discussing as a group would allow us to focus in on would allow us to determine as a group which would be the areas to, which would be the ones to basically charge a work group to work out the details and create and do the investigation report. So I think that there's that what I heard was described a few minutes ago as the different suggestions. We need to make an agenda. We will get a list from that from the minutes, but then we'll need to work on how to prioritize and agendify those. And so to me, that would be, well, we have to do that somehow. So we could either do it by calling each other in between, or by using our next meeting as like an agenda to work on, as an agenda item to work more deeply on those ones and prioritize them, decide which way to go with each.
Madam President, if I can make a suggestion, other commissions frequently have like a retreat for half a day or something where they can actually get together in a small group, or they get together as a whole at first, and then they discuss the major issues at large, and then they hold up breakout sessions so that they can actually talk about smaller issues among smaller group, and then they get back together at the end of the day, and then they talk about what should be prioritized within a given year. I think that may actually eliminate a lot of issues as to the ability to get together in a big group, and sometimes even in a smaller groups, sometimes it's difficult to get together outside of this kind of setting. So that, although it seems like a big time commitment at first, that is a very efficient way of getting everybody together and then sorting out the issues, perhaps for the whole year. But it's just a suggestion from what I've seen.
Right. So I would agree with that. I also agree with having sort of a hybrid approach. I just think that for some of the issues that we're working on, there are things that change over time. And particularly with the ACA, there are things that are going to change and rather quickly. And so we can decide on what the priorities are going to be, but the specifics of what actually would be under a specific subject of the report over time could change, particularly within the next 12 months. So that's basically my concern, is that the priorities on HIV/AIDS could drastically change given the money that's in the budget. The priorities on the ACA will change given how given the budget, the federal budget, but also how Congress decides to proceed, and then what our state's response is. So we may not, as a committee of the whole, be able to talk about the actual specifics in each one of those subcategories. And also, I think it's important to rely on our experts within our own commission in terms of bringing recommendations forward. And a group that's actually focused on that specific issue is going to be more likely to bring forward recommendations that are timely and have up-to-date information. So I would just caution that, because what it sounds like is that we're doing away with our subcommittees, and I would just caution against that, because just seeing sort of the flow of the work over the last year, which was very disjointed, given that it was our first year, I think now that we actually have a sort of process and we have a structure, to go back to changing that structure again, I think is going to put us in another protracted period of uncertainty where we don't know how we're actually working, we don't know what's brought forward to the Commission of the Whole, and people may not be focused on a specific issue, and may not be following it, and we may not have like the up-to-date information when it comes time to actually create the report. And so that would be my concern.
All that's true.
With Commissioner Braun as well. we could discuss as a group the priorities and the details based on these priorities, see which subgroup could follow up. And I can see, Commissioner Sharp's reasoning of our work last year where we just divided up into the subgroups and we tried to bring it up, but it was disjointed as an entire group. So if we could discuss in priorities, and as the city attorney has suggested, it might take a time commitment in the beginning, but then the follow-up could be done with the subgroups, and these subgroups can be reporting in a timely manner the progress or the changes that are occurring. But we have the general priorities for the whole year based on everything that we've discussed as important agenda items to discuss this year.
Commissioner Hawkes.
Kind of bring it full circle. I do understand the importance of having this. And first of all, the retreat is something I think I mentioned last year, so we could be all at the same table and focus on their priorities, number one. But two, it was a prime example today to hear about that presentation on the ACA, because what it meant to me was one thing, what it meant to Commissioner Mendel was another. And it resonated in different parts, so I think there is validity in having that more of a macro approach. At that point, we can go ahead and make that decision whether or not we want to break off and make a small subcommittee to deeper dive at that point. But I think it's beneficial as a whole for it to be presented more in the macro sense here, and then make a decision at that point.
Okay, great. I think
Can I clarify my request for motion was actually not identifying issues. I wasn't identifying issues that would be natural fits for subgroups. I was identifying different objectives for the commission. One, to try and have relevance and resonance with decisions that people here in the building are weighing, which may or may not be issues that we've identified as subgroups. That was sort of one priority. Second is getting funding. That's not a subgroup. It's sort of a process. And the third is trying to find out how to best intersect with the county. Again, that's not an issue. So I think that issues are a good way to break folks into groups if the objective is to write a report or to produce an annual report. And I'm proposing an alternate purpose, which is to try and figure out how to be effective in improving the health of residents. And I've identified 3 potential priorities for how to do that: get staff, try and figure out what people here in the building are worried about, and try and figure out how to intersect with county oversight. I don't disagree that there's all sorts of important issues that small groups ought to get together on. I'm suggesting a different set of priorities, really, than doing another deep dive to do another report. So it's not a contradictory approach, it's a different frame.
Right, with the recognition that we do need to have an annual report.
There is going to be, as I heard in the council committee hearing where I went to talk about the other thing we did on the city and county contracting, the city planning department is regularly being expected to report on an almost identical set of recommendations that are part of Plan for Healthy LA. There's another group that's reporting on the homeless organization. My hunch is, I say this as speculation, that there's insufficient distinction between the stuff that we're going to cover in an annual report and other processes. So my suggestion is that without staffing, we don't spend the huge amount of staff of time collectively to put together an annual report. That's implicit, I guess, and I'll now make it explicit in my set of priorities, not be to do another similar annual report, because there's other folks looking at the same problems, tracking and reporting on them in slightly different ways. Granted, not this group of expertise, but I don't think we have the staff resources collectively to spend the enormous amount of time that you and the CSUN students and others did on this. I'm suggesting a different approach for 2017.
So I think as part of the ordinance, actually, we are required to provide an annual report. I think also the issues that we've addressed in here actually are a little different. I really don't know of another report that's asking for the city to either fund or otherwise support Housing for Health, for example. And so, the question is whether or not we have a unique role, and that really was a question that was brought before the City Council when they decided to pass the ordinance that they passed to create this commission. So we do have this commission. There is an ordinance that states that we have to provide an annual report. So I mean, without changing the ordinance, which I would not be in favor of. We're not sort of, we don't get out of producing an annual report
There's
from the
three other
commission.
requirements that were in the ordinance we didn't complete last year. So I think it's just infeasible to do it without staff. We've not complied with any of the three auditing requirements. We didn't comply with the strategic plan part, which is separate from the annual report. We didn't comply with the attending all the county meetings. That doesn't, I don't feel any culpability. I mean, city attorney can tell me if we're liable in some way for not having executed things. We don't have resources. We're professionals, volunteers. So I don't feel held to that the same way. If we can achieve the broader objective, which is to help improve the health of city residents in some other manner, then I would advise that we try and do that. And I'm trying to test out a few potential hypotheses on how to, or methods to try and better improve the policy making at the city and county level around health. And absent, another $100,000 award or some huge amount of money to really staff this, I'm trying to suggest is there some other way to try and go about being relevant and functionally useful to the decisions, again, 4 or 5 major health decisions, not just in committee, but citywide, that were made last year that we didn't get to contribute to. How can we engage all that? That's what I'm trying to test out. We could do a deep dive on a number of these issues, produce another admirable report. That's an option. And I would love us to just consider some other options for how to spend our time and energy over the months ahead. Maybe this is where we come out. That's why I'm trying to lift it up, first meeting of the year. Happy to hear what others have to say and go with the will of the group.
I have a comment. And I guess for me, I don't see this as two competing things. I see one as sounds like a foundational process building strategy that could potentially inform some of the issue areas that we've talked about. So I guess maybe if I'm hearing it incorrectly, it's coming across like we're trying to decide one or the other, but I think that one can be a foundation for the other, or one is a process toward the other. So I would be happy to hear what other people are, what are they hearing in regards to the two positions that are being presented right now.
Commissioner Hawkes.
Just hearing all of this information, I think it comes down to, one, yes, we definitely need staffing. I mean, that's paramount. We can't keep doing this on our own and ad hoc and, on the backs of, great people. It's just that's the one issue. The second issue is, I'm not sure. The second issue is I feel like my priority and our priority should be is we were all given this responsibility so that we could recommend and advise our council members on health-related issues that are important to the city. And that's where I want us to be. So, and if it goes ahead and everything that we're building upon from, staffing to moving forward on the issues that are important to our city and our council members, so we can make coherent, well-educated decisions on our recommendation, that's my goal. So, and in the process, if we go along that way and we're in parallel with the Health Commission plus the City Council, it will eventually evolve over the year long, and at the end can be ultimately just not. I don't know if it's a report per se, but ultimately you'll have a fluid working document of everything that we've done along the year. So not more so as a structure, and because we were under the gun last year, we had 2 months to try to figure this out. So that was the priority. I feel like the priority now should shift to we're in advisory capacity, and that's kind of where we should be. And then as a result, maybe this document could follow. So ultimately, we do need staff.
Any other comments? I would really like to see how our report is received actually by the community and by the City Council before we make any decisions on how to move forward. I'd also, given the AIDS Healthcare Foundation is one who or had originally wanted a health department, and I guess there was an agreement between the city and the AIDS Healthcare Foundation in terms of, deciding instead on the ordinance and the commission. I'd like them to weigh in on this too, because I kind of feel like it's sort of maybe switching gears a little bit and sort of changing the path that we're on. And so so instead of making a motion at this meeting, I'd like to at least give this a month to see how our report is received and to hear from city council members and community members to get feedback, and then I guess make a decision maybe next month.
Circle back with our council members, with the report, and also try to get a pulse on what's their perspective and what are their priorities as well, so that we can come back the next session, having that ability to point out where our focus is.
So
I agree.
I have a recommendation. I don't know if it should be a motion, but using the minutes of these good ideas that have come up, which are different flavors, that each of us will speak to the councilman councilperson who has appointed us to discuss that menu and their awareness or reaction to the reports that we sent, and then we'll discuss what we learned at our next meeting.
I think that sounds like a good way forward.
Recommendation, can there be like a motion to maybe hold a retreat to further discuss the actions of the Health Commission?
Yeah, and my understanding is we don't necessarily need a motion. What we would need is to come up with a date, and then I think that would be a special meeting. Is that correct? Because that would be, we would all be meeting together, but it would be also a Brown Act issue, and that would then be a special meeting that would go out. Right, okay. Okay, so we don't necessarily need a motion on that, but we can, perhaps Candy can send out some dates or just ask the question on when people are available, and then we would just, have a larger treat. We could take a day, I suppose. We could do breakouts as well. And maybe I could talk to, or a few other people could talk to some folks who have done this in the commission, in other commissions, so we know how it was structured, and then we could move forward with that.
Candy, I can help put you in the right. We did it for the Housing Authority, and it was an open retreat out in the community, so that we didn't have the violation of the Brown Act, and we had other civic participation in the process as well.
Okay, great. Any other comments? Okay, so we will move now to public comment. Mr. Herman?
What's the hang up here? What's the hang up? The hang up is this. We come here to bitch on items as HHH. And who other than Herb, Hilda, and Hitler, who falsely represent public trust in their conditions? That's the wrong. That's why, politely, as Madonna said, fuck you. And as Madonna pointed out to me, and the crowd,
and to our detractors that insist that this march will never add up to anything, fuck you. Fuck you.
So the hang-up is this. Herb should step down. Hilda Solis should go get another job from with Obama, somewhere in the Bahamas, where your worthlessness of 8 years of doing nothing for the homeless that are in your street. HHH is a time to be reckoned. And how do you become efficient? You come to your meetings on time. Represent the public that you say you represent. 4 of you walked in here late, an hour and 15 minutes late. If you don't like the goddamn commission seat, move out and put someone in there who can protect my citizenship as an American fighting for the rights of advocacy for veterans in our country. fuck you.
Thank you. Mr. Spindler?
And to our detractors that insist that this march will never add up to anything, fuck you. Fuck you.
Yeah, well said. Yes, the big fuck you, yes. It's really true. Hilda, Hitler, Herb. Hitler puts them in the oven. Hilda comes from Washington to steal more money. And then that pathetic Herb Wesson, war criminal Herb Wesson, scumbag, uses a city attorney, Hugo Rossiter, 17 days before my arrest and makes up that fucking story in advance that he needs a restraining order. And you sit in these chairs. Mental health. You gotta be fucking nuts to use a city attorney and a bar card in the name of the city attorney of the city, the second largest city in the United States, to defraud me out of my civil rights, smear my name on media internationally on a lie, on a fucking lie. So I've got a little bitch, and his name is Marquise Harris Dawson, who was there on May the 11th. He's being sued because you know why? He's going to admit that he knows that Herb Wesson made that whole fucking story up. You know why? Because he doesn't want to lose his fucking house. That's why.
Thank you. Okay, moving on to item number 4, just discussion and or action for changing the regular meeting time of the Los Angeles City Health Commission. Does anyone want to comment? I don't know if the current time is working for most of our commission. I know it seems to be very hard to get here at 5 o'clock, given that traffic on the freeways is starting usually around 3:30 now. So if we could have some kind of discussion, and if the time is working for you, that's fine. Please let us know. And if it's not and you would like to change it, if we could start that conversation, that would be great. Commissioner Mandel.
It depends on the day of the week, because some days are, for some of us, are more flexible than others. In my particular case, Tuesdays and Thursdays, I have clinical responsibilities that are really limited. So I left my office at 3:40, which one would have thought would have been more than adequate time. At great expense to myself, I left it at 3:20. But it took me an hour and 40 minutes to get here. So which is totally unpredictable, some of which is related to some of the traffic down here. But if it was on Monday, Wednesday, I could have much more flexibility, so I can get here at 5.
Okay, great. I know I'm having a particularly hard time getting here by 5 o'clock. It's really
What would
hard.
be better for you?
So for me, a Monday or Wednesday is fine. If we could, and I don't know what everyone's work schedules are, but if we could even have a daytime meeting, sometime between 9 and 5 and maybe around 11 o'clock, it would be easier for me. And I would actually save probably more work time because I have to leave so much earlier to get here at 5 o'clock. So if we could meet either around 11 o'clock in the daytime during work hours or later at night, I think it would be just much easier in terms of travel time.
John Hisrick. I think the later at night would be difficult for city staff. I don't mean to speak for them, but that presumably would be a bit of a problem. Daytimes, I mean, I'm retired, so I'm pretty flexible on that. There are a few other meetings and various things, but I think daytime would probably be difficult for most folks. Mondays are better for me than Thursdays, and the Monday at 5 seem to be okay. I have no big desire to change it unless that's a big problem for everybody. I'm pretty flexible, obviously.
And the uniformed officers who protect us here, is cost the city significant amounts of money if we started at 5:30 or 6? Later, if we started later. Do we know what the impact and cost of the city would be?
No. I don't know. I could get the information and then let you all know.
Yeah, I think it'd be hard for us to make decisions that are going to hurt the city of Los Angeles. Our goal is here to help the city of Los Angeles and not cost money.
Right.
So if it's going to be, double overtime or some other thing, then I think we have to weigh that in our, process. If it's not going to cost more money, then, maybe we should do that. I have a lot of flexibilities on Mondays and Wednesdays, so as long as I know way in advance, I can schedule meetings during the day. For me, it's not difficult. Some of the other people have full-time jobs that may be less flexible. So, I'm willing to try to work with the commission, do whatever is the best for the consensus. But unfortunately, some of the people who aren't here now, potentially can't get here in the middle of the day. So.
Okay, maybe okay.
Well, personally for myself, Thursdays is the best day, but Monday can work. And knowing in advance, I could, arrange to be here earlier. I would just request that it wouldn't fall on the Monday mornings that the council, mental health, and education committee meets. They meet every other Mondays at 10:30. So if we can avoid that time.
Okay. Any other comments?
During the day would probably be a problem due to what my day job is. I'd probably be in some sort of conflict or would have to take time off, which would be weird. And then I also thought, well, it would seem that evenings would be better so that if folks wanted to come, the public wanted to come, they could get here. I'm sure they work during the day, and even if they don't, evening would probably be most advantageous to them. So just my 2 cents.
Dean, I think starting a little later would actually be helpful in terms of the traffic, but...
Yeah, I'm kind of feeling like the 5 o'clock time is, first of all, you have to leave work early, so it's already sort of disrupting a work schedule, and it's not, I feel, helpful for members of the public who also probably are not going to leave work early, and so we're not really doing much of a service to them, either.
So there's sort of two parts of it. One is the time of day, and then the other is the kind of day of the week question, because it sounds like some folks have certain obligations, certain days. And did I hear a slight consensus that Monday, in general, is a little easier? And then the question is sort of 11 a.m. or like 6 p.m. And I hear a little bit of 6 p.m. is a little easier.
Yeah, I think it's too hard for people to take off work. So if we could, because there are a number of commissioners who aren't here, if there's anyone, the city clerk could send out an email just asking people if maybe Monday at 6 o'clock works, and then we can, because we do need to make sure that we can meet quorum and have the majority, if not all of us, able to meet at that time. I think that would be helpful. And then, do we?
Time, or would that be?
Yeah, we could also, if you could also check in and see if there is like a financial impact on the city having it later. I think that's fine. I do, since we did establish our time Monday at 5 o'clock, just for the city attorney, a question for you. If we find that 6 o'clock is actually a better time, can we change that time without it being a vote today?
I forget what the ordinance says, but I really don't think it's going to be a problem changing the time. I think perhaps during the next meeting you can all get together and then agree on the new time, so that it becomes a new regular meeting. I think that'll be the way to approach it.
So for next month, could we have it at 6 o'clock if it comes back that, if it comes back, that's a better time for everyone? Or do we have to cancel that meeting and then make it a special meeting at 6 o'clock?
That would be the correct approach. Make it a special meeting at 6 o'clock. Cancel the regular meeting and then make a 6 o'clock meeting as a special meeting.
Okay, and then at the special meeting, establish the regular time, the
Right,
regular monthly time. And then, are people fine meeting the second Monday, or do we want to change that?
It's fine.
Are people fine with that Monday? Okay. So we would just be canceling the 5 o'clock and change it to 6 o'clock for the purposes of February, if that's how it comes back from the rest of the commissioners. Okay.
Appoints a new replacement for the individual. Is our quorum has to be 8 if we only have 14 standing members, or can the quorum be 7?
It has to be 50% plus 1, so it's still 8. 50% would be...
Right, got it. I can do math, thanks.
Okay.
Something.
Okay, great. So everyone is comfortable with proceeding, okay, that way. Okay, great. Okay, we will, any other comments regarding time and day? Okay, we'll proceed to public comment. Mr. Herman?
Regarding future discussion?
No, this is regarding the meeting day and time for the City Health Commission.
We're talking about our regular meeting times. It's kind of hilarious when you talk about time, because some of you have time to waste coming in here late, while us hardworking constituents have to sit here and bear the rhetoric. We have a purpose to criticize, and it falls under the Ralph M. Brown Act, 54954, parentheses 3, item C. And we do that in order to allow failure. And that failure is for a purpose. It reflects you're a cantor that doesn't exist. Because if it fucking existed, why aren't you doing enough for the homeless? Why are there so many people out on the street without health care, health insurance, health benefits, health service, health participation? You violate people's humanitarian rights to health. And even goats need health care. Animals need health care. And yet a human being laying on the sidewalk every day in the city of Los Angeles, and not one of you goddamn fools get out there and hand out that person an invitation to come in here and protest their rights on what you can do to better their life. Now that's fucking hilarious. I really got something to say, and it's all in my mind. And yes, it's an intensifier, reasonable and
Thank
offensive.
you. Mr. Spindler?
Yes, well said, Lily Allen, the great Lily Allen of London, England. So, yeah, 6 o'clock, that's not going to do it. You got to make this at 10 o'clock at night. That's right, in the ghetto. That's right. But you're going to save the money and security Well, you got not one, not two federal lawsuits. And you got to hire outside counsel to defend them because your attorneys are so fucking stupid and criminal and crooked and corrupt that they have a conflict of interest with Hugo Rossiter and his preconceived lies that he drafted over at City Hall East at the end of April. That he gave Herb Wesson a script to read from. I'm afraid, I'm afraid, I'm afraid. Your city attorney did that. I have all the documents. Englander, Kanabi, and Allen going over to the State Bar Enforcement Office, paying somebody off to move my case 9 months ahead of people who really need help. I got those documents. So you people are fucked, fucked, fucked. So let's pay this bitch with the puppet so he can get on with his life. So the FBI doesn't have to get the thumb drive today.
Thank you. Okay, moving on now to item number 5, items for future discussion. Someone like to begin comment on any items that you would like to take up, other than the ones that we've talked about in our discussions earlier? Okay then, great. We will move on to public comment. Mr. Herman?
So item 5. We are not participants in our own realm, but we are protectors when it comes to the health care of individuals who cannot defend their rights for health care. Majority of people under the ADA Title I and Title II, 121.32, have always been an issue of discrimination because most of the people in this commission that you service are denied participation to programs and the activities because you judge them. Like Herb Wesson, Hugo Rossiter, Judge Wayne Spindler, for the record. Under the TMU and the TRO, fuck you. And in 2008, when Tom LaBonge, Herb Wesson, and that other white nigger wetback, Jose Weezer, kicked me out of my community under the TRO, fuck you. When I was sick in my home and you pulled me out of my fucking house and put me in the street, fuck all of you. Fuck LA. That's how upset I am. But it's nothing personal. I'm being reasonable because I'm reflecting on the damage you caused an individual to see the real shit in life. And that's the reason why the real shit comes in here and bitch against the HHH. And you, Kevin DeLeon, you poverty pimp fucking senator, fuck you, AB 1618, because I'm going back to Sacramento next month for the record, puto.
Thank you. Mr. Spindler?
And you just have to imagine for future discussion how you are an attorney with 30 years of practice, Hugo Rossiter. And the end of April 2016, you can go to that building at city property and draft affidavits for a proposed TRO 17 days before it happens against me. You go out there, get a restraining order, and while I'm facing criminal charges on his phony fucking criminal, because they couldn't just go for a TRO. No, they got to go twice to the DA to want to file a felony. You know how much it costs to defend a fucking felony charge? Bankruptcy. That's how much. Okay? I don't give a fuck. So I told the DA in June the 10th, fucking file your charge. Here's my bar card. You know why? Because you people don't know anything about me. You don't know why and where I came from. Look down at the ground. I came from hell. I was born in hell. That's where I came from. That's what my face is. I'm the face of hell. And I turned my life around. 21 years of peace, working my job, defending people. You fucking people opened the gates of hell. You put me back where I was in 1989. Back to the beginning. So, later on, when you get your discussion with people that don't have a name and a face, but they got a badge, you tell them this. You fucking started this shit, and you better find a solution to it.
Thank you. Okay, moving on to item number 5, public comment. Hamini Parak, and I hope that I spelled that or said that correctly.
Good evening, and thank you all for your service and volunteering on this commission. My name is Jamie Parak. I am an attorney with Communities for a Better Environment. My comment regards Council File Number 150387S1 regarding the motion passed by the City Council Committee on Health, Mental Health, and Education requesting this commission to report back on health and safety impacts related to abandoned or unknown oil and gas wells. I'm here to submit a report that our organization prepared regarding 2 orphaned and abandoned hazardous wells located on Furman Street in the neighborhood of Echo Park, Los Angeles. We respectfully request the Commission review and consider the report for inclusion in its report to the Council. The Furman Street wells are orphaned oil and gas wells, meaning no existing entity owns or operates these wells. They're located in Echo Park, a densely populated residential neighborhood, and neighbors started complaining about them in 2014. Testing by the Department of Oil, Gas, and Geothermal Resources and the Air Quality Management District revealed methane leakages in quantities sufficient to create an explosion risk, and concentrations of hydrogen sulfide which exceeded California's ambient air quality standards by several orders of magnitude. Health risks associated with hydrogen sulfide include severe rotten egg odors as well as additional problems once the concentrations are higher, and that's all documented in this letter. So I'm running out of time, but I just wanted to kind of raise this issue for you, and also, one of the things the letter highlights is both the regulatory failure that resulted from this. The wells leaked for about 2 years before they were eventually capped, and they were capped at the cost of the taxpayers of California and the city of Los Angeles.
Thank you.
Yeah. So here are the letters. There's a copy for each of the commissioners that doesn't include the exhibits, and then one copy with all of the exhibits.
Great, thank you. Mr. Herman?
Wayne Spindler with a public comment card for drawings, First Amendment violation by the city of Los Angeles. There's Susan Rocha complaining about loud music from a church who blasts their noise, and she's detained by the LAPD and goes before a court and is thrown out. How many of these actions go on unnoticed? You don't think that creates a health concern to anyone? It does. And you should get on the goddamn ball and do something about it as you leave, Sharp. Think about it, dumb motherfuckers. It's something to do with someone's life, someone's family. And here's a good example. I can't breathe. I can't breathe. Daddy, Mom, I can't breathe. I can't breathe. You suck the life had mental conditions in OC. And now what? Ezel Ford, that bitch Jackie Lacey, what did she do to protect a human being's rights? Civil rights. Just because he was black and you didn't like him? Because he had mental health conditions? When a person's in a crisis, it's your responsibility to back off and deal with the crisis. Back off. Save a human being. But instead, HHH, Hilda Solis, Herman Herb Wesson Jr., whatever the fuck his name is, and Hitler had one thing in common. Taking a life doesn't matter. It shines no sun.
Mr. Spindler?
Well, we lost. Oh. See, this happens quite often. This is the new lawsuit that I'm preparing. It's called the on-purpose loss of quorum to stop puppet from speaking violation. And you see, what they do is, Michael Hunt was standing right here in 2009, and they lost a quorum. Next thing you know, he got $215,000. So if you'd like to pay us each $215,000, then you can just leave. See, we don't give a shit. Me, my puppet friends, other puppets, Herman, we don't care. We're here to work. We're here to bitch. And the sharp wasn't very sharp when he was going to leave the meeting through the back door with his tail between his legs, because he knows that Hugo Rossiter lied. He knows that Herb Wesson lied. He knows that Herb Wesson's mortgage is owned by Union Bank, and he never recused himself when he gave them millions of dollars of contracts. Did you know that? That Union Bank didn't foreclose on Herb Wesson's house while he gave them millions of dollars of city contracts? No, you didn't know that. Look at the shame on your faces. Oh, yes, you know. You know, no, you didn't know. You know. The two cops in the back knew because they have to get their pensions. So whenever they go to Herb Wesson, the police department gets 51% of the budget. You know why? Blackmail. Yes, they blackmail a blackmail. Well, what are you going to do? So we don't give a shit. Run away, Mr. Vice President. Run away to your car. Run away to your gated community. Run away to your liberal beliefs. But when you wake up tomorrow morning, Donald Trump is the president, Jeff Sessions is the attorney general, and you're fucked, all fucked.
Thank you. So I guess for lack of quorum, we're adjourned. Is that correct? We can adjourn for lack of quorum?
That was a general comment, so there's nothing to act on. It's really irrelevant.
Right, but do we need to entertain a motion to adjourn? I guess that's my question.
You can adjourn without a motion.
Okay, great. Okay, so the commission is officially adjourned. Thank you.